excellent meeting, but the topic that's been given to me, unfortunately, we don't use these things in our clinical practice, and we've forgotten about it ever since our medical days. So let me introduce to you this specific topic where we float a Swan-Ganz catheter into the heart and we get these numbers, and then what to do with these numbers. I don't have any disclosures for this presentation. So I will be discussing the indications, measurements, and then special case scenarios. So right heart catheterization was, it's a long concept, and the measurement of pressure started with Stephen Hills, who did his experiments in the horse where he measured the column of blood through the surgical exposure. Then Werner Fassmann was the first to introduce catheter into himself, and he ran to the radiology department and took a picture. Of course, he was suspended after that. Carl Wiggers was actually the first guy to include electrocardiogram with these hemodynamic measurements, which has led to establish the fundamental electrical mechanical intervals, which has greatly enhanced the understanding. So this has been a very exciting area, pulmonary artery catheter, which was developed by Swan and Ganz. It became in vogue and everybody started using it left and right. It was considered that without that you cannot treat these patients. Then gradually the studies came, and then the patients who were enrolled in the Pac-Man trial, ESCAPE trial, these patients were ICU, very sick patients, septic shock, all kind of shocks, and it was found actually right heart catheterization increases mortality and increases complications, and you don't attain any further interest. And then pulmonary artery catheters became out of vogue. And even today, in my hospital, if I ask a critical care specialist to float a Swan, they are not very well versed with it. So we involve our cardiac anesthetists into this. And in fact, as cardiologists, we did it wrong back, but then we're relearning how to use these catheters. And that's why we are doing it, because now, again, we are seeing that pulmonary artery catheters are good, because the data from the CSI, Bill O'Neill's data, and then other trials have shown that if we use these catheters along with the mechanical circulatory support, along with the Impella, which Dr. Martin Leons talked about, then it improves survival, and that's considered one of the good practices. And we'll talk about it, how it is important to monitor right heart pressures and other parameters while we are managing these sick patients. So these are the indications for hemodynamic monitoring, which includes shunt calculation, which includes pediatric interventions, which includes pulmonary evaluation, pulmonary artery hypertension evaluation. But in our clinical practice, the predominant usages are, these patients have had beautiful echocardiography, and this echocardiography has developed so much that we get a lot of data from there. But still there's a lot of discordant between the findings, and somehow we have to arbitrate as to whether the patient is having the particular problem or not. And also in RCCU, we need this to manage our critically ill patients, and then as an adjunct to interventional surgical procedure, and also in acute and chronic heart failure, including MCS patients. So how do we go about it? Of course, there are a lot of direct measurements that are done. All these pressures are to be measured in all the chambers, which include right atrium, which include RV, which include pulmonary artery, and then as we further go up into the pulmonary capillary wedge position, then we get these pressures. And of course, we measure saturation in all these areas. And we also get the mixed venous oxygen saturation, which is very important marker for cardiac output and other parameters. And then what we derive out of it, we derive the flows, we derive vascular resistance, and we derive certain other parameters which we'll talk about. And these are the calculations that are made, and I would like you to make a note of it, that each individual parameters have got very important role in management of these patients. Transpulmonary gradient, which is the difference between the mean pulmonary artery pressure to the pulmonary capillary wedge pressure, and the normal is less than 12, that suggests that the hypertension, the pulmonary high pressures which are there, they are not related to lung disease, and still the pulmonary vascular resistance is still uncontrolled. And these patients can be, you can go for the heart transplant and other devices in these patients, or right heart or LVAD in these patients. Also, the pulmonary vascular resistance, it's very important to, instead of we are posting these patients for heart transplant, then if the PVR is high, the new heart will fail, and the patient is not a good candidate. So I encourage you to remember this, that RA is equal to central venous pressure, and from there, if the tricuspid valve is competent and it does not have restenosis, then the RV diastolic pressure is equal to RA pressure, then the blood goes into the PA, and the RV systolic pressure is equal to pulmonary artery systolic pressure in the absence of the pulmonary valve disease. And as you go into the wedge position, then you are actually looking at the left heart from there. So you remember these numbers because it is very important for you to interpret these numbers to interpret these waveforms along in the light of these normal values. Of course, there is a lot of variation to it and you cannot generalize, but then these basic ideas should be there. Coming to individual wave analysis, RA pressure, as I said, is equal, CVP is RA, and then it is consisting of 3 upward waves, which is the A wave, C wave, and V wave, and 2 descents, which is the X descent and Y descent. Each wave has importance. That A wave is the part of atrial contraction, and it is the actually active ventricular filling, and because the atria is contracting at that time, and 30% of the cardiac output is because of the atrial contraction. And this is, at the ECG, you can see that this is at the level of PR interval, and that's where after that the C wave comes, which is at the time of the ventricle is started contracting, the tricuspid valve is closed, or the on the left side the AV valve is closed, and that has caused this indentation. The X descent is because of the atrial relaxation, and then comes the V wave, which is because of the atrial filling. Now the passive filling of the atria is occurring, and at the Y descent means then when the tricuspid valve opens and there is a ventricular filling is occurring. So what are the causes of increase in RA and CVP? Anything which increases the volume in the body will increase CVP. So either volume overload, blood volume is increased, or the right ventricle is failing. That means there is a lot of backlog there, which will increase the CVPs. Also, if the patient has disease of the subsequent valves, both tricuspid and pulmonary, then also the CVP will go up. And in other areas like cardiac tamponade, positive pressure ventilation, also this will go up. What will cause reduced RA and CVP, which is hypovolemia, or if patient is on beta adrenergic, or if the patient is having a lot of vasodilatation. Coming to RV, similar, it has systolic, it has systole and diastole, which has phases like isovolumic contraction, rapid ejection, and slow ejection, and diastole has isovolumetric relaxation and then passive and rapid filling. Of course, it has atrial filling also, and the end diastolic pressure is the way to go forward, because that's the measure for the preload. So what causes elevation in RV pressure? Similarly, the RV pressure will go up if there is a RV failure, if there is a pulmonary valve disease, and there is a pulmonary hypertension and chronic left heart failure. So it is important to, in both left and right heart failure, you have to understand that if the RV is generating certain pressure, then the RV is still having some life and it's not totally gone. In pulmonary artery analysis, it has systole, diastolic notch, and diastole, and the pulmonary artery pressures go up in the left-sided problems as well as right-sided problem. It is important that you don't see these waveforms in isolation and you see the complete study, then only you will be able to understand whether the problem is related to the left side of the heart or the right side of the heart, or both. Then comes the pulmonary capillary wedge pressure, which is the occlusion, and then once normally the pulmonary capillary occlusion pressure or wedge pressure should be equal to the LA pressure, and that should be equal to the LV-EDP, which is the preload. And it does not equilibrate with LV-EDP if there is a mitral stenosis, if there is crotariatum, if there is a left atrial myxoma, or any other veno-occlusive disease of the pulmonary circulation. Normally, once you occlude the balloon into the pulmonary artery, then that directly look into the left atrium. So actually it looks through the pulmonary circulation to see the left atrial pressure. But this will happen only if the catheter is in the zone 3 of the lungs, because there is an interaction between the alveolar pressure, the pulmonary artery pressure, as well as the LA pressure, and the LA pressure is best mimicked if the catheter is in the zone 3. So these are the reasons for pulmonary capillary wedge going up and down, and they are very similar to the left-sided waves. Normal is 4 to 12. If the left heart failure is there, then the capillary wedge pressure will go up, like LVMI, aortic and mitral valve disease, cardiac tamponade, and also if the LA pressure, if the pulmonary capillary wedge pressure is normal, that means that it's primarily disease of the right heart. That's very important to understand, and these pressures, this ratio of CP to wedge is very important to diagnose right heart failure. So we see these PA, pulmonary artery pressures and pulmonary capillary wedge pressures in together, because that will differentiate between whether it's a primarily lung disease or left heart disease. And this is the hemodynamic classification of pulmonary hypertension, which suggests that it can be either pre-capillary or post-capillary when the mean pulmonary artery pressure is more than 25, and then if the pulmonary capillary wedge pressure is normal, then this is pre-capillary pulmonary hypertension. That means either it is pulmonary artery hypertension or it is the chronic lung disease hypertension. It could be post-capillary if the pulmonary artery pressure is also high and the pulmonary capillary wedge pressure is also high. That means it is primarily because of the left heart disease. So basically CVP and PCWP, they all have, both have similar reasons to go up and down, and I've discussed all that. Now I would to give you this concept of cardiac output. This is very important to understand these pressure volume loop relationships, which I'm not going to detail because that's not the topic here. But the cardiac output is predominantly governed by preload, contractility and afterload. So preload is basically the hemodynamic load or stretch on the myocardium at the end of diastole. That means the LV and diastolic volumes. Now if you see that if you increase preload, the contractility or the cardiac output will increase, but that doesn't occur in failing heart. The patient becomes preload unresponsive and works in the flat area of the curve. That means that if you increase the volume, even then the cardiac output will not go up. Afterload refers to the hydraulic load against which the heart has to pump. That is the systemic vascular or pulmonary vascular resistance. It can be also be a measure of the blood pressure. So if you reduce, if you have to act on these specific parameters, you want to treat these patients of shock and heart failure. Contractility is basically the intrinsic ability of the myocardium to contract. It can be modified by the number of functional myocytes, like in the patients with acute myocardial infarction and ischemia, the number of myocytes will be less, or they could become asynchronous, or the drugs like positive and negative inotropic agents can alter the contractility. So coming to the cardiogenic shock and heart failure, the classification is based on hemodynamics as well, where depending on the cardiac index which is normal or low and the pulmonary capillary wedge pressure which is either normal or high, you can change these, you can define these shock parameters, and then the worst form of cardiogenic shock is when the patient is cold and wet. So these shock subtypes, and of course Sanjog has great collection of that. These how do you distribute, how do you differentiate between different paratypes, like either it's a hypovolumic shock, or it's a distributive shock, or it's obstructive shock, or a cardiogenic shock. And it is very important to diagnose this upfront before you start thinking about these mechanical circulatory support devices or other parameters. You have to know what is the primary cause for this shock state. So in hypovolumic shock, understandably pulmonary capillary wedge pressure will be low because the patient is hypovolumic. The cardiac output will be low, the SVR will be high to compensate, and the missed frequency oxygen saturation will be normal, or it could be even slightly higher in the early stages. If it's a distributive shock, that means septic shock, when the systemic vascular resistance is very, very low, the cardiac output is actually high because it's a primarily high output failure, and the mixed venous oxygen saturation will be high. As against obstructive and cardiogenic shock, where in the cardiogenic shock the SVR will be high, the pulmonary capillary wedge pressure will be high, and the cardiac output will be low. Yesterday Sanjog was talking about the this mixed cardiogenic and distributive shock, which we see in those patients in which we have done a procedure, and I've seen this in ECMO patient as well as in patients on Impella, where the cardiac output is looking normal, but the patient is not doing well. He's still cold and clammy, he's still in shock, because there is a mixed picture now. The patient is having both distributive as well as cardiogenic shock, and where the SVR is low, and that is leading to this kind of picture. This could be very confusing. So this algorithm suggests that once you diagnose cardiogenic shock based on the index and the pulmonary capillary wedge pressure, then initial management is of course inotropes, and then you should do a multidisciplinary shock team consultation, and then based on that the therapies depend on the further parameters. It's very important to do right heart catheterization now, because if you don't do that, you will not know whether this is predominantly LV shock, which means that the LV cardiac power output is low, and the pulmonary artery pulsatility index is normal. That means the RV is normal. That means the RAP to wedge ratio is low, and because the pulmonary capillary wedge pressure is high and the RA pressure is low. Or it is a right ventricular shock, where the pulmonary artery pulsatility index will be low, the RA pressure will be high, the LV-EDP or the pulmonary capillary wedge pressure will be low. That means the pulmonary capillary wedge pressure, the CVP wedge ratio will be low. Or this is a biventricular shock where the parameters both will be abnormal, where PCWP will be high and the RA pressure will also be high. And if the patient is, then the patient will require both right-sided as well as left-sided support. And if the patient is hypoxemic, then probably VA ECMO is going to be the best in this scenario. So this is how to diagnose RV failure. These are the parameters which are there. You check the right heart to pulmonary capillary wedge pressure. The cutoff is 0.63. Of course, there are caveat to that they are mostly defined in the setting of left ventricular assist devices or the left heart support devices. But then still they can be applied to clinical scenarios in general. Of course, pulmonary arterial pulsatility index, the PVR and the PA compliance are also important to calculate. A word about the exercise right heart catheterization, which is now becoming a very common elsewhere as well as now coming up in India, where the patient exercises and is being continuously monitored with the right heart catheterization. And this is the Peace algorithm, where either you use HFA, HFpEF algorithm, or you use the HFpEF algorithm by Barry Borlaug. And if the patient is in intermediate risk category, then right heart catheterization is used, where the pulmonary capillary wedge pressure of more than 25 or a pulmonary capillary wedge pressure to cardiac output ratio of 2 millimeter Hg per minute per liter is considered as the diagnostic of HFpEF. So I'll leave you with this, where the right heart catheterization along with these markers of right atrial pressure, RV pressure, PA pressure, pulmonary capillary wedge pressure, and all those calculations gives us excellent idea as to how to treat these patients in chronic heart failure, in acute cardiogenic shock, and in patients who are requiring LVAD as well as right heart catheterization. Thank you.